we will discuss about the most frequent bone tumors, malignant bone tumors, and we will start with osteosarcoma. Osteosarcoma represents a malignant tumor that produces bone tissue. It is very important because the cells that we are finding on the biopsy, it will be bone tissue. It is represented by the most common of malignant bone tumors. Where is the localization of that type of tumors? It is localized on long bones, metaphyseal, epiphyseal, around the knee and the humerus. It is most frequent in male comparative to female. At clinic, we will find osteocopic, nocturnal pain, swelling, viscous attitudes, and in many cases, you will find a fracture or on abnormal bone. On the X-rays, the abnormal presentation of that X-rays, it is represented by the osteolytic area without well-defined contours with cortical interrupted and periostal reaction. Like in that image, you can see the specific grass image, spicules on the periosteum. It is in the most frequent image for that type of bones, of the malignant tumor in bones. You can see here the cortical is interrupted. You can see here an osteolytic image and the reaction of periosteum. It is represented by many types of images. In that example, you have an osteolytic sarcoma with an osteolytic area on the X-ray. It is the most common represented on the knee, on the proximal part of the femur or the distal part of the tibia. It is the most frequent localization. It exists some types of osteosarcoma that are represented by osteocondensation. You can see here osteocondensation with an imprecise side of normal bone to abnormal bone. It is a specific image for osteosarcoma with the type of osteocondensation. In that image, you don't have any reaction of periosteum, but in time, it will appear. And if you look with attention a little bit here on the lateral part of the distal part of the tibia, it is a little bit periosteum reaction, and in the posterior part of the tibia. But in time, it will appear that periosteum reaction. In many cases, you can see the osteosarcoma with mixed lesions, with osteolytic and osteocondensation with periosteum reaction. By localization, it could be two big types of that bone tumor are represented by the center form, like in that image. It is on the center of the shaft of the diaphysis, or you can see the peripheral form. The biology is poor. It is represented by some modifications about ACR or increased alkaline phosphatase, but in most cases the biology is poor and you are not able to put a correct diagnosis or orientated at the correct diagnosis. Sorry. Macroscopically, we will have some fleshy look, gray. The tissue, it is encephalon-like in many cases, and you can see some calcifications. At the macroscopically, sarcoma cells with osteoid tissue, because it is a bone tumor that have bone cells, and you will find that bone cells on the histopathologically exam. But you will see, in comparison with the benign tumor, the anarchic spans. You will have to ask for more types of investigations for making a correct diagnosis, and in all cases you have to ask for CT and MRI and scintigraphy. It is very important to make that type of investigations, because it exists a discrepancy between the clinic, the radiological exam, and that exams that could see the extension in soft tissue of our tumor. The arteriography, it is very important to make, because you will have a view of the vessels, and you will have a view of the irrigation by the tumor, and it is very important that you can make some embolizations for to reduce the risk of metastasis, and to reduce the risk of bleeding in time of the surgical intervention. What's the correct treatment for that type of tumors? Are represented by the chemotherapy, but you will have poor results with that. The most important, the key of treatment in that cases of osteosarcoma are represented by the surgical intervention. Our surgical intervention in that type, we are talking about malignant bone tumor, and it is very important to make a radical one. Even if we are talking about the amputation, disarticulation, or even if we are talking about the big resection and reconstruction with different types of surgical interventions. The radiotherapy has less effective, and we cannot use in that type of bone tumors. For example, to see the discrepancy between the X-ray and to see the extension in the soft tissue, we have made the resection in that type of osteosarcoma on the proximal part of the femur. Is the type of osteosarcoma that have osteocondensation on the X-ray, and we have the central type of osteosarcoma. On the X-ray, you cannot say that you have a big extension on the soft tissue, but intraoperatively, macroscopic, you can see we have a big extension of the cells tumor on soft tissues. In that case, we have made the correct resection, an oncology resection, that we have removed all the tumor, and we have made a reconstruction with a special prosthesis. It is a special one. We use that type of prosthesis. You can see it's a big one. We are using just in case of tumors. Doesn't matter if we have a malignant or benign bone tumor. Other type of example of osteosarcoma on the distal part of the femur. You can see we have osteocondensation and osteolysis. You can see here the reaction of periosteum. It is an unprecise delimitation between the normal bone and the abnormal bone. And what is here, we have made a big resection with removing the bone and the soft tissue that was affected. And we have put special prosthesis, tumor prosthesis after our resection for the reconstruction. Other example of an osteosarcoma in a young people, you can see here we have the tumor that are represented by osteocondensation. We have interrupted here the cortical bone. You can see here the reaction of the periosteum and some osteolysis here and here. What was made a big resection with removing the whole bone tumor, and we have made we have put a special prosthesis that was recommended in that case. You can see the postoperative images, the anterior view, the lateral view. You can see we have a good mobility. That's an X-ray inflection of the knee, and you can see that we have a very good mobility and very good we have established very good the wide bearing and the function of the knee, and it is very important for our patients. In some cases, you can make other type of intervention. That's an arthrodesis. We are putting a nail on the central medullary nail that we are locking with screws, and we are putting a graft from the tibia. It is a lift in the normal part of the bone that we are making that arthrodesis. The function, it isn't like in prosthesis, but we can preserve the limb, and it is very, very important. It is an example for an osteocondensation osteosarcoma, an example for the osteocondensation type of osteosarcoma. Other examples for reconstruction with big bone grafts, with the lift of the graft of the tibia from the part that we have normal bone. Other example for peripheric type of osteosarcoma, that we have a big reaction of periosteum. In the peripheral type of osteosarcoma, the reaction, it is better seen on the X-rays. You have here the anteroposterior view of the knee, and here the lateral view of the knee, and you can see it's a big periosteum reaction. That means we have a soft tissue, an important soft tissue it is affected. Other image that you can see, it is a big discrepancy between the X-ray and the MRI and CT, and you should ask anytime to see the soft tissue invasion and to put a correct diagnosis, and you have to ask for that type of investigations. That's an example for an arteriography at that patient. You can see we have big vessels that goes in our tumor, and that's pre-embolization image, and that's after that we have made an embolization on the tumor. You can see the vascularization, it is very good here, and it is a problem with metastasis, with bone tumors on distance, and the bleeding in the time of surgery. And it is very important to ask and to make the arteriography and the embolization to reduce that risks. We have to measure the tumor intraoperatively, because you will have to make a reconstruction, and you will have to make where you have to cut, where you have the normal bone, where you have the abnormal bone to remove, and then to make a correct reconstruction. That's the image, intraoperatorily image, that we have made the cut on the middle part of the tibia. We have removed the tumor, the bone tumor, the soft tissue extension, and then you can see we have clean tissues there, and we are able now to make the reconstruction. That's our prosthesis that we use in that case. It's a big prosthesis of the proximal part of the tibia. We have removed the proximal part of the tibia, and then you have to make a reinsertion of the patellar tendon. It is very important to reconstruct the extension apparatus, and it is very important to make that soft tissue to put on our big prosthesis. You can see here we have hydroxyapatite on the prosthesis for a good integration for our soft tissues. And that's the final step of the surgical integration, surgical intervention, when we have made some sutures of soft tissues to cover our implant. It is very important to make a correct cover of our implant. And here you can say it's a very good post-operator X-ray image after the surgical treatment. That's a big prosthesis of the knee, a tumoral prosthesis, a special one, and it is adaptative according to our removing, to our bone cuttings. Other type of...
I think you might want to change your Mac to charge it. I don't know if you plugged it in.
Okay.
Low battery.
Thank you. Other type of malignant bone tumors are represented by the parietal osteosarcoma. That's a special one because of the localization of that type of osteosarcoma. It is represented by a tumor that are localized juxtacortical osteosarcoma. It could be a low-grade malignancy up to 500% of total types of bone tumors, malignant bone tumors. The localization, it is similar to osteosarcoma, but we don't have a bigger percentage to male comparative to female. On the X-ray, it is a specific image. You can see here, it is similar to the peripheric osteosarcoma. The localization is on cortical bone, just on cortical bone, but with extension on the middle and the lateral part, and with periosteum reaction. It is hard to put the diagnosis just on image if you have a parietal osteosarcoma or the peripheric type of osteosarcoma. The biology, it is it don't have a specificity, it is poor. What's the treatment? The treatment is similar with osteosarcoma. You have here an extracompartmental extension, and it is very important to make a correct surgical intervention, plus minus reconstruction, amputation or reconstruction, but it is very important to make a radical surgical intervention. The chemotherapy under evaluation, it is hard to say. In most cases we cannot use that chemotherapy pre or post-operative postoperatively. We are discussing about the chemotherapy just in metastasis. If you have osteosarcoma, doesn't matter if it's a parietal one or a peripheric or central form, doesn't matter. You cannot use chemotherapy on osteosarcoma, but just in case you have metastasis, and just for metastasis you will use that chemotherapy. The key of the treatment are represented with the surgical intervention with a good resection. That's the image of parietal osteosarcoma. You can see it is similar to the peripheric osteosarcoma. You can see the reaction of periosteum. You can see here the osteocondensation. Macroscopically, intraoperatively, the osteocondensation look like in this image. What have we done at that patient? We have to make a big resection with reconstruction. In that case, you have to know that reconstruction, we are making the reconstruction in cases that our patients don't have any metastasis. Because we have some metastasis, the evolution in time, it will be not good, and we want to rehabilitate that patients. We want to reestablish the function in the patients that we know that we will have a good evolution. Why? Because it's a big surgical intervention, and the patient has to be healthy to make that surgical type. That's a young patient with an osteosarcoma, the distal part of the femur that we have made a resection. You can see here how good is our flexion, how good is our extension, how good is our function of the knee, and the postoperative evaluation, we are happy to see that patients with that mobility and that life quality. Other example of periosteum reaction in a young patient with osteosarcoma. You can see here our surgical time intervention that we have made. We have removed the whole tumor, the whole bone that was affected, and the soft tissue that was affected. It's a big tumor, and you will have to make a big reconstruction. You can see here the hemorrhages, the part of necrosis of our tumor. You can see here the osteocondensation that we are seeing on the X-rays, and you can see here the abnormal tissues that we have around the bone. That's an extracompartmental malignant bone tumor, an extracompartmental osteosarcoma. And then you can make some reconstruction. That's an example for a tumor that are affected, extraarticular affected on shaft, on diaphysis, and we have made a reconstruction with a gamma nail, with a special gamma nail that we are using on that type of malignant bone tumors. You can see here the postoperatory image X-ray on the femur, the front view. The chondrosarcoma is the second tumor of the malignant bone tumors. From frequency, it can be primitive or secondary. The localization is on the base of the limb, on scapula, or on iliac wing. Male are most common in male, then female, the 3 to 2 is the percentage, and the clinic is the same to osteosarcoma. There exist on the X-rays 3 forms of that type of malignant bone tumor. It exists the central chondrosarcoma with the variable size and geodas, irregular polycyclic contour. It could be peripheral chondrosarcoma and clear cell chondrosarcoma. That has the worst evolution, the clear cell osteosarcoma. It is the most aggressive of all chondrosarcoma. The central and the peripheral chondrosarcoma have a good evolution in comparison with the clear cell chondrosarcoma. The biology is like osteosarcoma is poor. We have ACR increase and phosphatase alkaline increase, but we don't have some paraclinic investigations that could tell us that we have a chondrosarcoma. That's an example for the central chondrosarcoma. You can see here that we have osteocondensation on the central with osteolysis, emphasizes the limitation between the normal bone to abnormal bone. That's on the proximal part of the tibia, and that's an example of chondrosarcoma on the proximal part of the humerus. You can see here that we have osteolysis. We don't have a big periosteal reaction, but in time it will appear. For peripheric, we have a periosteal reaction in most cases, and you can see the abnormal tissue, abnormal tumor on the peripheral part of the bone. The bone look quietly normal, but if you are making a CT scan or MRI, you will have a big affected of the bone from the tumor. The clear cell osteosarcoma, it is represented by the tumors that have a big center osteolysis. Where is the localization? The localization is on the proximal part of the bones, even it's on the head of the femur, distal part of the femur, on the condyles, or the proximal part of the tibia, on the tibia plateau, or on the head of the humerus. The treatment, how to choose our treatment. The surgical treatment, it is the key of our treatment, like in osteosarcoma. We have to make big resection, oncological resection in normal tissue, and we will have to remove all the abnormal tissue. It is hard but you will have to make that, and sometimes macroscopically can be normal, but you can have some skip metastasis because of the periosteum reaction. It means that we have an extracompartmental bone tumor and we have soft tissue invasion, and that means we'll have to make a big surgery for removing all the tumor cells. That's an example for a big tumor, an chondrosarcoma of the proximal part of the femur, that we have removed all the tumor and all the soft tissue that was affected, and we have put that special prosthesis, a big one, and it is a hard surgical intervention to remove that tumor because of the bleeding, because of the skip metastasis, because you have a big affected of the bone. That's an example of other resection and reconstruction after chondrosarcoma. Other type of tumor are represented by the fibrosarcoma. That's a malignant tumor developed from the fibroblast cells. That means on the biopsy, on the histopathological examination, you will find fibroblast cells, and it will go for the diagnosis of fibrosarcoma. Where is the localization in half of cases on long bones around the knee, metaphyseal with metaphysoepiphyseal extension. It is in young patients and it is equal male to female. On the X-ray, what kind of lesion you can see? There are no typical images for that type of bone tumor. You will see a big invasion, you will see osteolysis, osteocondensation, and you will see periosteal reaction like all of the types of the malignant bone tumors. Was the treatment chemotherapy, unspecific, effective, preoperative and postoperative, and you will not have a good response on the chemotherapy. The key of treatment are represented by the surgical intervention, like in osteosarcoma or chondrosarcoma. That's an example. You can see here we have a pathologic fracture, abnormal bone, osteolysis, osteocondensations with periosteum reaction. And what have we done? We have made a resection, a big resection of the proximal part to the middle part of the shaft of the femur, and we have put a special prosthesis, a tumor prosthesis for reconstruction. Ewing sarcoma, it is a special sarcoma, it is frequent, and it is a special sarcoma because the treatment is a little bit different. Is the second malignant tumor in young people after osteosarcoma. It is frequent. The localization on long bones and flat bones, pelvic, femur, tibia, fibula could be anywhere. But in most cases, you will see that that type of tumor on the long bones, on the part of the shaft of the long bones. It is represented the most common on young patients, and you will see that that periosteal reaction. Why it's different, the treatment? The treatment it's different because you can use radiotherapy. It is radiosensitive tumor and it is very good to use that radiotherapy. Could be for treatment to disappear the tumor, or could be to make a smaller tumor, to make a good resection and reconstruction after that radiotherapy. And it is very important that in that type of tumor, if you have after biopsy the diagnosis of Ewing sarcoma, you can use that radiotherapy and you will have success. That's an example for resection and reconstruction after Ewing sarcoma, after we have made the radiotherapy, and then you are able to make that resection and reconstruction with good results. That's another example. You can see it's not a specific image for bone tumor. It is specific for all malignant tumors. You can see here the periosteal reaction. You can see the osteocondensation and osteolysis, but you can see it is a big tumor and a poor delimitation between the normal and the abnormal bone. On the scintigraphy, you can see we have metastasis on distance. You can see on the ribs, on the knee, on the ankle. You can see the discrepancy between the X-ray and the MRI, and it is very important for the soft tissue evaluation to make that type of investigation. Here we have the angiography. You can see it has a very good vessels that are alimenting our tumor. But after embolization, you can see we don't have a similar image to the pre-embolization image. You can see we have made a reconstruction. Yes, it is exception. I've told you that it isn't good to make reconstruction, resection and reconstruction in malignant bone tumors when we have metastasis, but in Ewing sarcoma after the radiotherapy, our metastasis could disappear, and you can think about resection and reconstruction in that case. You can see here it's a big resection with normal tissue here that we can cover our implant. You can see the special prosthesis for the proximal part of the femur. You can see here some holes for insertion the muscles, because in rehabilitation it is very important to cover very good our implant and to establish our muscles, our anatomy, our local anatomy to have good in time resection. That's an image, a post-operatory image that we have made. That resection is a big one. We have just the distal part of the femur that arrestance it's with a normal bone. All of the abnormal bone was removed, and we have put that special prosthesis in that case. Lymphosarcoma, Parker-Jackson, it's another type of malignant bone tumor. Large cell lymphosarcoma derived from lymphocytes, and you will find on the biopsy the lymphocytes. The localization to metaphyseal, diaphyseal on the long bones, it doesn't have a predictive type of age, and it is equal male to female. On the X-ray, you will see some stains osteolysis with or without cortical disappearance. The osteolysis, it is very important in that type of tumors. It looks a little bit like giant cell tumor, the giant cell tumor that is a benign tumor, and it is very important to put the correct diagnosis, because the treatment is different. That's a malignant tumor, and you will have to make a correct surgical intervention. You will have to make a big resection and to remove all the tumor cells. That's our X-ray, that's our postoperatory X-ray. We have made a big resection and reconstruction with prosthesis. That's another example. You can see here the osteolysis. You cannot see here very good periosteal reaction, but it exists. On the middle part of the cortical of the distal part of the femur, you can see here the periosteal reaction, and you can see the osteocondensation and osteolysis lesions on the distal part of the femur. On the scintigraphy, you can see and you can say it's a metabolic active tumor, and you will have to make a biopsy. You can see here how big is the discrepancy between the X-ray to MRI according to the soft tissue extension. You can see here the arteriography that was performed for our embolization, pre-embolization images and after embolization images. Here we have the surgical time, the surgical intervention, the surgical view, you can see the abnormal tissues around the femur that we have to remove. That was after removing of all the tumor, the bone tumor and the soft tissue extension. You can see here the osteolysis macroscopically. Here we have some holes, and here we have osteocondensation. That's corresponding to the X-rays, the macroscopically one. And this is a reconstruction with cement, that we have made in that case for reconstruction. In time, if you have a good result, local and distance, and we are talking here about the metastasis, you can make the final surgical treatment with a special prosthesis, a tumoral prosthesis in that patient. That's an arthrodesis with a centromedullary nail and the cement. Here we have cement, and we are waiting in some cases that we are not sure about the extension. We are waiting and we are choosing the time of the final surgical treatment with special prosthesis in some cases. Multiple myeloma, it's another frequent tumor that we have, or malignant tumor. It is a hematological malignant proliferation of secretory plasma cells, and you will see plasma cells on our biopsy. It is most frequent in male than female, and the clinic is it isn't specific. It is specific for all the types of malignant tumors. But here you have an exception of biology, because you have some special analyses that are modified in that types of tumor, and we have increased immunoglobulin alpha 2, beta, immunoglobulin G and A, and that if we have that immunoglobulin increased, if it's present, you should think that could be multiple myeloma. Other specific analysis for that type of tumor, it is represented by the Benz-Jones protein in urine, and it is very important to determine that paraclinic investigation to put a correct diagnosis. But the final diagnosis, like in all bone tumors, doesn't matter if it's a malignant tumor or benign one, you have to make the biopsy and then to make the surgical treatment, because the final diagnosis, it will be on our biopsy. The treatment in multiple myeloma is the exception for our tumors about the chemotherapy, because it is the first choice, and we'll have to make that treatment, and then in case if we have resistance of tumor, of bone tumor, you can make the resection. But in some cases, the final treatment are represented by the chemotherapy. But in some cases, you will have to make surgical intervention. But the surgical intervention is just for the solitary plasmacytoma, because you can make a wide resection and radiotherapy. Myeloma prophylactic osteosynthesis, in pathologic fracture, you have to make that prophylactic osteosynthesis, because when you have many lesions, it is impossible to treat all the lesions, and chemotherapy and radiotherapy could help you in that case. The specific images on X-rays for that myeloma is osteolysis. It doesn't matter where you found that osteolysis. Could be on ribs, could be on femur, on humerus. you can see on ulna, like in that image, but in most cases there are multiple lesions, and an investigation that will help you very good for that type of bone tumor are represented by this scintigraphy, because you will see all the bone lesions for that type of tumor. And the last malignant bone tumor are represented by the metastasis. The metastasis could came from two sources: the visceral malignancy known or unknown. It is a problem when you have visceral malignancy unknown, because you will have to put the diagnosis by making on biopsy on our bone tumor. And you will find that cells from the primary tumor, and it is very important if you have metastasis on the humerus and you don't know where is the primary tumor, you will find the cells from the primary tumor and you will have the correct diagnosis. It is the most frequent bone tumor, malignant bone tumor. It is the most frequent because could appear from all the organs or the cavities, and you will have to treat correct. And to know how to treat correct, you will have to make a biopsy and to know where is the primary tumor. There exist some types of osteocondensating metastases are represented from the primary tumor on the breast or on the prostate, or osteolytic on the thyroid, lung, and kidney. It is hard to say where is the primary tumor. You will have to make that investigation, the X-ray, and then it is very important to ask for a scintigraphy to see the whole body and to determine the number and the localization of the metastasis, because in most cases we don't have a single one, we have many metastases on different bones. The clinic, it depends, the localized or diffuse, not exacerbated, could appear in most cases, and it is the first for diagnosis, the spontaneous fractures, and it has that clinic presentation with a spontaneous fracture. The biology, it is not specific in that type of tumors. We have that three forms of metastasis on X-ray: osteolytic, osteocondensation, and in some cases you can see mixed appearance on our X-rays. What is the treatment? The treatment depends the type of the primary tumor and depends the number of metastases. Why? Because if you have a unique metastasis, you can think about resection and reconstruction. Why? Because you can treat that metastasis and then to make a correct treatment for the primary tumor. But if you have multiple metastases, you can make just comfort osteosynthesis for preventing or for treating the fracture on pathologic bone. And it is very important to determine if you have a unique one, a unique bone tumor, a unique bone metastasis, or if you have multiple metastasis. That's an example for unique metastasis on the femur, and with a pathological fracture that was treated by resection and reconstruction with a special prosthesis. That's other example of unique metastasis with resection and reconstruction. But if you have metastasis, multiple metastasis, you will be not able to treat and to make a correct resection on all lesions. Thank you. If you have questions. Nobody?